I think we'll kick off if everyone's happy to go. So thanks again for joining us today. My name is Tara Regan and I'm Communications and Advocacy Manager at Arthritis Ireland. We really appreciate you joining us today. We're going to be talking about foot health and arthritis for this webinar. A very interesting topic, and I know it's one that we get a lot of questions about regularly. So I'm so delighted today to have two expert speakers with us, Sandra Caulfield, who is Clinical Specialist Physiotherapist, and Yvonne Buckley, Clinical Specialist MSK Podiatrist. And they are both based at the HSE Mid-West Foot Clinic. So I'm going to just introduce our speakers very quickly to you, and then we move on to the topics of the day. So just to introduce Yvonne first, Yvonne has been working as part of the HSE Mid-West Foot Clinic since October 2020. And as part of her role as a specialist MSK podiatrist, she works on upskilling her podiatry colleagues and working on research, which is currently in the area of osteoarthritis and orthosis. She has a very keen interest in orthotic design, gait analysis and technology, and speaks regularly at conferences around the importance of foot orthosis in the offloading of the high-risk foot. Yvonne is also a member of the ULAR Foot and Ankle Special Interest Group. And Sandra also works, but she works as a clinical specialist physiotherapist in the HSE Mid-West Foot Clinic. Sandra works in the area of musculoskeletal physiotherapy and has been doing so for 17 years, where she specialises in musculoskeletal and rheumatology conditions. She uses a combination of manual and exercise therapy to empower patients to self-manage conditions, and is also a qualified Pilates and yoga instructor. She also enjoys teaching, and research that she's been involved in includes telehealth outcomes in rheumatology MSK triage, which was during the COVID-19 pandemic. And Sandra is also a member of the ULAR Foot and Ankle Special Interest Group. Then just a little bit about Arthritis Ireland, as some of you may not be familiar with the organisation. We are the national charity and patient organisation for those who live with arthritis. We deliver support, training, education and information. I would encourage you all to have a look at our website, arthritisireland.ie. There is a huge amount of information there about arthritis and related conditions, including information booklets. We run a very significant suite of self-management programs. We have podcasts, we have recordings with clinicians, and we also have blogs. You can subscribe to our blogs and our newsletters. I would strongly encourage you to visit our website and avail of all the information there. We also have a free national helpline, which is open from Monday to Friday from 10 AM to 4 PM. And the helpline number is 0818 252 846. And you can contact the helpline if you need support or information, or even if you want to register for a self-management program. Just in terms of the organisation itself, we rely on the generosity of the public to ensure that we can continue to provide services and supports to everybody living with arthritis in Ireland. There are lots of ways you can support the organisation. You can make a one-off donation, or you can set yourself up for monthly donations. And there's a QR code there on the screen. If you want to use that, you can scan it and make a donation that way. Or if you would like, you could also organise a fundraising event. And if you visit the fundraising section of our website, you get a lot more information there about how you can get involved in becoming a donor or fundraising or donating to the organisation. Just in terms of a little bit about housekeeping today for the webinar, it will be recorded and available to view on our YouTube channel afterwards. And anyone who registered will receive a link tomorrow to the recording. Everyone except presenters and speakers are on mute and their cameras are off. And we would ask you to put your questions in the Q&A function in Zoom, and we will allocate 15 minutes for the Q&A at the end, and we'll take as many questions as we possibly can. So thank you very much, and I'm going to hand you over now to Sandra and Yvonne, who are going to speak about different areas of foot health, and like I said, we'll take questions then afterwards. So thanks so much, Yvonne and Sandra. Really looking forward to this, and I'll hand over to you now.
Thank you. I'll just share this. Okay.
Thanks, Yvonne. Thanks, Tara. So the aim of today's presentation is to educate and empower you to care for your feet and to spend some time learning about your feet so that you can improve your mobility or maintain your current foot health. I suppose what we know from our own clinical practice and from research is that patients with arthritis do not feel comfortable or are not confident doing foot checks and caring for their feet. And this can lead to injury, discomfort, joint changes, risk of ulceration, and a period of time off your feet. Thanks, Yvonne. You can skip on there.
As the lovely introduction by Tara was, I'm Yvonne, and my special interests are gait analysis, orthotic design, hiking, coffee, and sourdough bread.
And I'm Sandra, and my time is taken up by my two beautiful little girls, but I also have a big interest in exercise therapy, yoga, Pilates, horses, dogs, and full moon circles. And we'd really both like to thank Tara and Arthritis Ireland for inviting us to speak today on foot health in rheumatology. This is a hugely ignored area in rheumatology and under-resourced, and it is a hugely impactful area for patients when we look at a holistic approach for caring for our patients with arthritis. So chartered physiotherapist, just to give you a background, we do a 4-year degree course or a 2 years master's degree course, which includes 1,000 hours of clinical training in a hospital or a clinical setting. And this is working alongside doctors, surgeons, OTs, nurses, and many other healthcare professionals. And the training encompasses all area of medicine, so cardiovascular, rheumatology, general medicine. So physiotherapists are very well placed to care for patients with arthritis, because as we know with arthritis, there's many multi-systems knock-on effects. So we have a good understanding of listening to what your needs are and how we can help you. So if you come to a physiotherapy session, you'll be assessed on that day and provided with education on your particular condition or the diagnosis that you've received. You'll be given specific exercises to your assessment. So the muscles that may need to be strengthened or different ways that we can help you. Motor control is something that we use to help protect a joint or stabilize a joint. Gait re-education, orthotic prescription, footwear advice, hands-on manual therapy to the muscles or the joints. We provide taping to offload any vulnerable or stressed joints or tissues, and load modification. And this is when we might ask you to increase the amount of work you're doing or decrease the amount of work you're doing to help promote tissue healing and recover from whatever your injury is.
So then on the other hand, podiatry is the 4-year degree in foot and ankle, and it's 1,000 clinical hours of experience as well. There is actually a master's course opening up in Ireland, and it's very new in Ireland. I think the first graduates were only in 2008. So there's really 3 areas to podiatry. There's a skin and nail treatment, which we often call as routine treatment, and this is the diagnosis of issues and treatment of these pathologies. And then there's the at-risk foot, so that's foot ulcers that you'd often see with diabetics and with people with rheumatoid arthritis. Then there's the offloading aspect of that. We do a lot of vascular and neurological foot checks. We prescribe orthotics. We do ankle and foot arthroses, so they're AFOs that are kind of non-complex. We issue footwear and we give footwear advice, and we also give exercises, and we do the load modification also like physios. But the real aim of both of our treatments as physios and podiatrists are to reduce pain, to restore or improve function, and to improve your confidence and mobility in your feet. So the overview of this presentation is we're going to talk about the importance of foot health. We're going to go through some rheumatological conditions. We are going to talk about what we do as healthcare professionals and how we can help. We're going to teach you how to do a foot check. We're going to give you some footwear advice. We're going to touch on orthotic therapy, and we're going to talk about physical activity and exercise and when to seek professional help. So the foot is so complex. Like Leonardo da Vinci was obsessed, so we should be too. So the foot has 28 bones. It has numerous ligaments and tendons. And a joint is where a bone is connected to another bone by ligaments and a joint capsule. And there's many different types of arthritis, as you all know, but they all can affect the joints of the feet. And the muscles and tendons and ligaments can also be injured. And there's also a lot of blood flow and a lot of nerves in the foot and ankle.
And our feet connect us to the world. So our feet are complex engineering mechanisms, which are actually miracles. And we're still learning how the mechanics work and how they function and how they propel us forward without allowing us to fall. A lot of the research that we have had up to the last decade has been based on assumptions made in the last century. And now we're learning from, I suppose, updated investigation that we can use that a lot of our assumptions are incorrect. So for instance, we used to think that a flat foot or a low arched foot needed arch supports because it was more prone to foot injury or it was a lesser foot. And that was actually a cultural assumption rather than based on actual scientific data. And now we know that that isn't true, that a flat foot is just or even more effective than any other type of foot. So our feet help us to move, to climb, to shock absorb. Our feet are very important for giving us information to the brain about how we can plan our movements and coordination. And also our feet, if they're flexible and strong, can help our pelvic and our core stability, and also help us prevent falls. So our feet are multi-systematic reasons to being strong in our feet and understanding how to use our feet better.
So why is foot health important? So up to 90% of patients with rheumatoid arthritis will experience foot pain or swelling or dysfunction at some point. And early intervention can reduce the risk of those joint changes and deformity and maintain the function and quality of life. Keep you doing what you want to do, basically. There is a risk of foot deformity, which you all might know. There can be decreased sensation. We can often see patients with ulcerations, neuropathies, and blood and vascular supply changes. But there are guidelines out there. Now, guidelines are very individualized. There is the BSR, British Society of Rheumatology guidelines are due in 2024. And there's this lovely guidelines from Williams et al. In 2011. But as all guidelines should be individualized.
So in clinic, we see many different forms of arthritis. One of the most common forms we would see is osteoarthritis. And osteoarthritis is a degenerative joint pathology. So the changes occur to the joint, the capsule, and the muscles over time. We also see a lot of rheumatoid arthritis, the psoriatic arthritis, the spondyloarthropathies, and these are inflammatory arthritis. So it's a different disease process. And once you've had that episode of inflammation, that's when the joint changes occur and the changes occur to the capsule. So it's not to say that one arthritis is more painful than the other, but we know the medical and the pharmacological management of these diseases are quite different. So with the rheumatoid, you might be put on methotrexate, a disease-modifying agent, or a biologic. And with osteoarthritis, it's more around pain relief. What we know from what we do in clinic from a mechanical musculoskeletal perspective is that we focus on protecting the joints, offloading the joints, improving the muscle strength and the capacity of the muscle to protect the joints. And then we focus on load modification and exercise therapy. So our approach to all of these disease processes are very similar from a mechanical perspective. So some common presentations that we see in clinic, plantar heel pain is one, and this is where you have pain on the base of the heel, particularly the first step pain in the morning, or it can be pain after prolonged periods of standing or walking. This was previously known as plantar fasciitis, and in the dark ages, maybe known as heel spur. And if we looked at, say, 200 people in a room and we x-rayed 50% of you, 50% of you are likely to have a heel spur, which is a little continuation of the bone here, where the plantar fascia attaches from here to the ball of the foot. That is not to say that your heel is always painful. So just because we see a heel spur on an x-ray, it's not to say that you have pain in your heel. So it's probably an outdated concept. What we know the problem is when the muscles are weak in the foot, that then there's overload in the plantar fascia. We also see a lot of metatarsalgia, and that's pain under the ball of the foot or around the toes. And that's probably one of the most common presentations we see in clinic, particularly with our rheumatoid patients. Nail pathologies are very common, particularly with our psoriatic patients, and fungal pathologies we would see in a huge amount of our patients, particularly with any vascular concerns. Corn, callus, fat pad atrophy. So your fat pad is cushioning tissue under the ball of your foot. So it's nice fatty tissue that's there in a healthy foot. And with different conditions, you can have the fat pad can get smaller, so it can become atrophic, or it can move forward and become subluxed. So it's no longer providing shock absorption to these bony joints. So that's something that we look at in clinic with footwear and with orthotics to provide cushioning for these bony joints for push-off in walking. Corn callus, we spoke about that. Achilles tendinopathy. So the Achilles is a tendon that comes down to the back of the heel, and with overuse or maybe not strong enough muscles, you can have pain in your Achilles. You can have arthritis of any of the joints of the foot and the ankle. Flat foot is a very common referral we get into clinic. But again, as we spoke about earlier, flat foot is actually normal unless it's painful. And there is a condition with flat foot where the toes can start to go out to the side and the heel can start to go out to the side because there's not enough support with the arch from the muscles in that area. And that is a really complex presentation that would need maybe particularly an orthotic or an ankle foot orthotic even. Bunions, when the big toe starts to drift in towards the lesser toes, and you get this bunion on the side, an enlargement of the bone here. Claw or hammer toes, when the toe starts to bulk up, and Yvonne has pictures of that in a minute. And symptomatic hypermobility. So hypermobility is extra bendiness in your joints. And a lot of people will have hypermobility and have no problems, but some patients will have pain with their hypermobility. And generally it's because the muscles actually have to work harder to control that increased range of motion at the joints. Thanks, Yvonne.
So I suppose a bit of a trigger warning here now if you're not into foot pictures, because this is the part where we have those foot pictures. So as Sandra referred to, a lot of these are forefoot pathologies where there's issues with the actual front of the foot, I suppose. And so if you look at the top left corner, you'll see a lovely bunion. So we often call that hallux adducto-valgus. And what happens is the big toe at the very far edge of it curls in along. So what often can happen is there's not enough space. So the toe claws up and it triggers. And often we will see corns, calluses, and blisters on the tops of those toes. Sometimes they don't even touch the ground, like in this photo here. So the big toe is only a bit anchoring, but all the lesser digits, we call the 2 to 5 digits in the podiatry world, the lesser digits, which is probably a bit cruel, but they are elevated, and that can be a big problem for finding footwear, because as you can imagine, they will rub off the top of shoes. But like this lady, she actually was hiking twice a week, so it didn't stop her from doing any activity. It was more that the footwear was the real difficulty for her. And then the bottom picture on the left, that is a more extreme version of a claw toe where the second toe is actually sitting on the big toe. And then on the bottom right corner, we do find there is often changes with the midfoot where the midfoot can collapse and the bones can become really prominent and can be sitting on the ground as people walk. So this is a callus on the navicular bone of one of our patients, and that you can imagine can be quite uncomfortable and painful. So then there's obviously nail changes as well. So on the left-hand side, we have some of the psoriatic nails that we would see. And with psoriatic nails, you can see pitting on the nails. You can see a lot of crumbling, and that's because with the psoriasis, there's a lot more keratin being produced, so a lot more nail cells being produced. So it can make the nail really crumbly and thick. And obviously that appearance can be a bit distressing for people. So sometimes they put on kind of a shellac or nail varnish, which can actually make it worse. And then it's often misdiagnosed as a fungal infection. Fungal infection has a more yellowy tinge, and it's often a lot thicker and grows higher. And like fungal infections are really common, but often misdiagnosed as well. So some podiatrists would have a kind of a quick nail test kit, which would take 5 minutes to diagnose whether it is fungus. Otherwise, you can go to your GP, but it's just, I suppose, a good clinical eye will be able to differentiate between a fungus and a psoriatic nail. And then you have in the middle, you have a lovely picture of some trauma to a nail. So obviously, if you drop something on your nail, the nails can bleed in between the nail cells because they're made up of loads of little layers of tissue. And that can be quite black and can go quite dark, and that's the blood underneath the nail. And that can take up to 12 months to grow out. It depends on how fast your nails grow. And sometimes podiatrists will need to take away some of that nail to make sure that there's no ulcer underneath the nail, because we're not always sure whether there's an ulcer underneath the nail or is it stable, and that's whether it's spongy or not. A little bit of a red flag is if you see a single line on a nail, single dark line on a nail, that can be an indication of a melanoma. So if you see anything weird and wonderful with your own nails or unusual, don't hesitate to see somebody about it, a dermatologist or a podiatrist. So as I mentioned, fungi is fun. A little bit funny there. So fungal infections are so common. I'm sure I see at least one a day in clinic, and it might be the main reason why they're in with us. So fungal nail infections are generally more common in people with sweaty feet. So a lot of people will also have a skin fungal infection called athlete's foot, or tinea pedis is the proper terminology. We do see an increase with shellac and nail varnish being put on because there's no oxygen getting to the nail. So the nail doesn't get to breathe. And repeatedly putting on shellac to cover up the nail is not going to solve the problem, obviously, either. So you can kind of avoid it by minimizing how many manicures you get. And even if you're putting on nail varnish for like an occasion where the toes are out, try and remove that nail varnish in a few days afterwards, because that can really stain the nail. And it might be a light kind of covering on the tops of the nail, but if you can get it off nice and early, that's better. Don't let it grow out. Dry well in between the toes. And sometimes we say to people, use kitchen towel if needed, because a big fluffy towel can be quite difficult to get in between the toes. Try and use cotton socks or natural fiber socks. Bamboo socks are getting more common now, and they can be lovely and a bit warmer in the winter as well. Socks, you need to put them in for a hot wash if you do have fungus. A lot of our 30 degrees are cold washes, although are great for the environment, don't really kill any fungus. So if you have a fungal infection, there's probably a good likelihood that they are living in the socks and the shoes. So we'll try and put on your socks if they'll take it into a higher wash if you can. Also have antifungal powder on standby if you are predisposed to it. I am a sweaty person, I'll put my hand up, and if I do start swimming a lot, I will be predisposed to a fungal infection. So I do have a supply at home of antifungal powder and products just in case. And if you do need to be a bit more aggressive with your treatment, there is Lamisil and Dactarin cream, which is available over the counter, but obviously talk to your pharmacist to make sure that is appropriate for you. Fungal nails, they take a while to go. They can take up to 12 months. So you have to be really patient. You won't see changes overnight because it has to grow out from the actual nail plate. So like, and no one treatment suits everyone, and there's so many different products out there. So just be patient with it. So then we have some skin changes. So as some of you might be probably aware of, there are things like corns and calluses, and these tend to form over areas of high pressure where there's a bone is easily like felt, or where you use a lot. So often it's on underneath the big toe. We get a lot of corns and calluses, and these are really common for people with any arthritis conditions. And they can be very painful. A lot of people liken them to like being on a pebble when they're walking. So obviously the top left side, yes, left side, there is some lovely corns there. And a corn generally is more conical. It's got a center to it. A callus is just layers and layers of hard skin, and generally one's not far from the other. And then on the bottom corner is actually a skin fungal infection that was mistreated for months, came into me, and I was like, let's try Lamisil for 2 weeks, and it cleared up instantaneously. On the top right corner is just, I suppose, to know there is a difference between a verruca and a corn or callus. Verrucas often tend to have little black dots in the center, or they tend to be quite white around the edge, and they bleed quite easily when they're debrided back by a podiatrist. So it's just to know the difference, and there are different treatment plans than corns and calluses. And the middle picture there is a man with rheumatoid arthritis that attends our clinic, and this was him 6 months or 12 months ago, and he got a pair of orthotics and he stopped smoking, and now he has no corns or calluses anymore, which is really great. There is a tenuous link between smoking that it's not really researched, but it is there between smoking and corns and calluses. So we all love our creams, lotions, and potions, and we all get Christmas gift sets of lovely creams that smell lovely, but also probably aren't the best thing for your foot. So the real thing that breaks down any callus or any cracks in the heels is urea. So read the back of the ingredients, make sure urea is high enough up there. The two main products that we'd recommend are Flexitol or Dermatonics. And again, no cream between the toes because we don't want any fungus. The other big thing is to avoid corn plasters. Corn plasters are the enemy of podiatrists. What happens is they have acid in them, so they actually burn the healthy tissue around the corn, which then when you eventually need to go and see a podiatrist because you didn't deal with it right, it ends up being really hard for the podiatrist to actually take the corn and the calluses away, and it's more likely to bleed, and that makes it all uncomfortable for everyone. So instead of trying to treat these things yourself, go and make an appointment with your local friendly podiatrist. We're very nice people. So just, I suppose, you should be checking your feet daily. I know a lot of people don't enjoy looking at their feet, but we put on shoes and socks every day and take them off in the evenings, hopefully. So if you can, you should be checking your feet at that time, and it's really quick. So you really need to be looking at the nail length. Is it too long? Is it pinching at the edges? Is it red because of that? Is there any new discoloration? Looking at the skin, making sure it's not flaky or itchy, because that could be a fungal infection. Is there any redness? Is there any blisters from any inappropriate shoes I wore yesterday? Is there any dots? Structure, look for any changes to the bones on my feet. Is there any swelling? Is there any kind of redness on the prominences? Have I had pain today? And are there any new calluses or corns on the foot and ankle? Obviously, a lot of people come in and they say they never look at the bottom of our feet. If you can't bring up your foot to look at it, use a mirror and then you can see the bottom of the foot, because often they're the parts of the foot that things often more likely go wrong. So morning and evening, guys, take off the shoes and socks and have a look.
So I'm going to introduce Maura. Maura would be a typical patient that we would see in clinic. So this story may resonate with you. She's a 60-year-old lady with a 20-year history of rheumatoid arthritis, which is managed by methotrexate. She'd never seen a physio or a podiatrist before, and one of the advanced nurse practitioners in Croom referred her to us. She has midfoot arch, so in here, and heel pain, particularly in the morning after prolonged standing and after walking. She complained of ball of the foot burning, calf cramps, and bunions. But although these were some of her complaints, her main complaint and the big thing that stood out, she was in a joint clinic with myself and Yvonne, was that she hated her feet and hated her footwear. She brought in a bag of shoes and she pulled out her good shoes, which were a pair of pumps from Penneys that she wore to funerals. And her main goal was that her son was getting married in March, and because she had no shoes to wear, she had nothing to wear. And this was really upsetting for Maura. So Yvonne's going to go through what she did with her in her first assessment.
So obviously we would have educated Maura on foot checks and hygiene as a starting point. We always check pulses. Generally, as podiatrists in our notes, we also have pulses checked. We would have cut and filed all of her nails. We would have taken back a corn on her second MTPJ, which is under the ball of the second. And we would have performed a biomechanical assessment, and we would have educated her on footwear. And just a note about cutting nails: cut straight across, don't start rounding into the edge to make them look pretty. You're more likely to get an ingrown toenail if you start cutting down the sides of the nail. And I suppose a note on footwear: shoedipity, the art of wearing ridiculously uncomfortable shoes because they look good. I am guilty of that. I suppose most women are. And there is research into the effect of having rheumatoid arthritis and foot deformity and going shoe shopping. And I suppose this is just a side to say, yeah, we know it's actually quite tough. And that compromise between comfort and looking good is really hard. So I suppose we are aware of it, and it is hard to get across that. But I suppose every morning when we get up, we're probably thinking which shoes suit my outfit best. And I suppose we're thinking first about the practicalities, what I actually have in my wardrobe. Number two is the purpose. What am I doing today? Am I going for a walk with friends? Am I going playing tennis? Or am I going to work? So obviously we wear different shoes for different occasions. And then it's obviously we want to look good before we go out the door, and feel confident. And then there's that pressure. It's like if we are going to meet family and friends, we want people not to comment on, oh, those shoes don't really go with your outfit, or those shoes look a bit granny-ish, I suppose, is often a term that people say when they come into us. So there are the classic orthopedic shoes that we do issue to patients. The black ones, I suppose, they have all the good qualities that we're looking for. But thankfully, I suppose we are trying, and the shoe companies are trying to diversify. And I suppose that lovely silver one is a very popular shoe amongst our patients because it looks a bit more like a stylish runner that you'd see in the high street. But I suppose it's a big thing to be 80-20 rule. So 80% of the time, if you're wearing your good orthopedic shoes, that's great. If 20% of the time you have to put on those kind of sparkly, not so perfect shoes for you, that's fine too, because we're all human at the back of it all. So we're going to talk about what you look for in a shoe. And so I'm going to demo the kind of orthopedic one, and Sandra's going to demo the kind of the high street one. So it's a New Balance, is it, Sandra?
New Balance 860. Yeah.
Lovely. Nice and fashionable. So obviously we want to look first at the length. So we want to make sure that it's the proper length for you. Generally there should be a thumb width plus or minus at the very top of the shoe. And it should be a nice round toe box if possible, or as wide as possible at the toe box to give you enough space so that you're not cramping the toes. And that's the width as well at the side where the bunions will be as well. So you want it to be as wide as possible there. You want a strap to be secure, so Velcro if needed, or even laces are even better. Try and avoid slip-on because that can encourage your toes to claw to keep on the shoes, and then that can exacerbate your biomechanical problems. So I'm not a big fan of slip-ons. Try and go for something with a good heel counter so that it has a lovely and firm support and it really grips your foot. And if possible, try and make sure that the heel height isn't too high so that you're not teetering on an edge and there isn't a big jump. Then obviously depth, we discussed the claw toes, that as much depth as possible to avoid rubbing on those toes. And just as long as it's comfortable around anything. And then the sole is very important. So good grip. We live in Ireland, slippery surfaces, it's raining today. So you need to make sure that there's a good sole and lots of grip on the bottom of the shoe. And then another thing that podiatrists and physios love alike is if you can take out the insole out of the shoe, because that is a bonus for us if we have to give you an orthotic. So yeah, there is a more detailed kind of list that you can look at if you are going shopping before you buy. Things to learn.
So things to consider before you purchase. Always buy for the bigger foot and pick up the shoe in the shop and make sure that it's light. So particularly with arthritis, we tend to have, our legs tend to be a little bit weaker, or they can be. So you don't want to be dragging around heavy shoes for the day. So nice light shoes. If you are prone to swelling, try on your shoes or go shoe shopping later in the day so that your foot is already swollen. Always wear socks or stockings for hygiene purposes. And where possible, the uppers could be made from natural fibers such as leather, and this reduces the chances of rubbing and sweating and then development of corns. And also with the runners, try and look for that there's no seam at the toe box. Either way, there's no seams along here or here. So then you're less likely to develop any corns or blisters on the top of the toes, particularly if you've claw or hammer toes. Avoid buying online. Sometimes there's no choice, particularly when you're looking for a wider shoe. If that's the case, check the returns policy. And I often ask patients, even in shops, to check the returns policy, because a lot of shops will accept a shoe back if you've only worn it indoors. And that's when you can trial a shoe and make sure it's comfortable. Also in the shop, I always say to patients, wear the shoe around the shop or if they have a treadmill for 15 minutes before you buy it. And if there's any discomfort at all, or it feels a little bit loose or is feeling a bit tight, just don't buy it. Be very careful. Something I've seen very recently on Instagram is a lot of influencers going into shoe shops, doing the foot scan where they're running across the foot scan and then they're saying, oh, I need this runner because of this. There's no data or scientific base for any of that. So go back to the properties that we just talked about, maybe screenshot it when you're looking at the recording and kind of go through nice stiff heel counter. You can't squeeze it in, that's cupping the foot. And those type of aspects rather than what maybe they're saying to you in the shop. We would say, particularly if you have arthritis, avoid slip-on shoes or wellies because they do make your forefoot, your claw toes a little bit worse and you might be already predisposed. And also wellies don't have a lot of support in them. So if you're any bit vulnerable to having a bit of midfoot pain or heel pain, it's going to flare up if you're wearing wellies. So if you have to wear them, fine, maybe look at getting an orthotic for your wellies for the winter time, but otherwise wear good hiking boots and that'll give you good support at the midfoot and at the ankle and offload those vulnerable joints. At home, try and wear slippers with a good Velcro strap like Cozy Feet or Guineas do them as well. Otherwise you're risking falling in slippers. Replace all shoes once there's sign of wear. So you'll see from my runners here, although there's not a lot of mileage done, there's a lot of wear along here. So this is called the EVA, the sole of the shoe. And when there's signs of wear here, it means the shoe isn't doing its job for shock absorption and not doing its job to propel you forward if you need that extra bit of support. So let your shoes go once you've seen there's signs of wear. And normally we'd say to people who are walking, maybe 6 to 9 months is where you're looking for signs of wear on the EVA. There's a lovely little opening or an eyelet up here. I don't know, can you see it? It's also in the orange circle down below. And this is called the heel lock. And there's lots of videos on YouTube where you can thread the lace through and then thread the lace through again like a bunny ear. And that lock your heel back into the counter of the shoe. Now in the Asics shoe, the laces aren't quite long enough to throw the heel through, but most runners, the lace is long enough to pop it through. And if you can get your heel stuck into the back of the shoe, there's less sliding, so less risk of blisters or frictioning. But also when your heel hits the ground, when you're walking, you're nice and stable, so it's supporting the joints, and then you're much more stable to go through and gait. So the shoe is able to do a lot more for you. It's much more efficient for you. A common question we get is around summer footwear. So we'd often recommend, again, leather type sandals with thick straps. Birkenstocks for a lot of patients are sufficient because there's a little bit of padding and there's a little bit of crest under the sole, under their toes. But again, you just need to go into shops and see what's comfortable for you. So just to continue along that line, as I said, Cozy Feet are a lovely slipper, and they also do wide fit shoes, and Mobility Genie have them online. I'm sure they're in other shops as well. So a lot of the medical shops that would sell commodes and such will have those kind of slippers. Pavers.ie is an online shoe shop, but they also have shops in these locations. They do lovely kind of formal shoes, or even more dressy runners that have a wider toe box and a deeper toe box. Marks and Spencers and Next both do wide fit dress formal shoes for male and females, but they don't have the additional toe box space. So if you have a hammer or a claw toe, they may not be the right fit for you. We talk about sometimes to patients about rocker sole runners. So a rocker sole runner is when you have this sole and you can't bend it at any point. So you can see me now in this runner, I can bend it here at the forefoot where my big toe is. But in a rocker sole runner, it doesn't have that flexibility. So rocker sole runners, there's a lot of research on these in our arthritic population. They offload the pressure that goes through the forefoot and the midfoot. So there's a lot less stress going through joints that might be sore or painful. Brooks Ghost are the most common one that we see patients wearing, or that we would recommend, because they also do a wide fit. Some of our ladies like to wear the men's size, so they don't have to go for the wide fit. They feel it's a more comfortable fit, and the men have lots of different colors too. So it's just a good option to think about. Brooks do a lovely walker runner, but it's hard to get in shops in Ireland. It's definitely in shops in the UK, but you can get it online. Another shoe that has lovely leather upper, round toe box, a good stable heel or a sole is the Propay shoe and runner, and you'll get those in Shaw's. Hokas are big on Instagram at the moment. They're everywhere. You've probably seen them. They look lovely. Just be cautious with the Hoka. They're a lovely rocker sole runner. There's different types of series within that. They have a very thick base. So if you're someone who's had a fall previously, or your balance is a little bit off, or you've lost a sensation in the sole of the foot, then that thick heel is going to more likely create an instability for you, and you're more likely maybe to have a fall with them. So be very careful. If you're going to buy a Hoka, you need to go into the shop and make sure they feel safe and secure for you. And just to mention then, the Asics are a lovely shoe for a narrower foot. So a lot of our mixed connective tissue disease patients, like the scleroderma patients, would have a narrower foot than, say, some of our rheumatoid or osteoarthritic patients. The Glide Ride is a lovely rocker sole runner, and it's hard to get in the shops in Ireland, but you can buy it online. But the Nimbus and the Cumulus also have very good stable soles, so they're good options in shops to try as well.
So orthoses or arch sports or insoles are a real popular opinion, and everyone probably has different opinions on them. But their real aim is to offload stressed or vulnerable tissues in arthritic joints or ligament tendons, and really good at offloading corns and calluses that keep on coming back. They really provide additional cushioning and shock absorption as you require. And there is some evidence for use in rheumatoid arthritis patients and in juvenile idiopathic arthritis with early intervention, and they can really reduce the risk of joint changes. Now, often there's a big difference between off-the-shelf and custom, but generally, if you need something quite fast, and there's no deformities, an off-the-shelf device like this is really appropriate, and they come with all sorts of additions to alter in the clinic. So most of the population normally go into an off-the-shelf if possible. Then you have your more custom devices, and these can be really sleek, and you can have all these different design properties, and they can really offload the front of the foot with different additions, and they come in fun colors too. So for Maura, going back to her, So we issued her with a slim custom foot orthoses that were custom made because of the forefoot issues. So we would have put a cutout for her second MTPJ to offload that fully and to give her a bit more padding at the forefoot. But it's sleek enough that it should fit into runners really easily. For the, as Sandra mentioned, we recommend, and it was a rocker ghost with the wide forefoot and redistribute the pressure. And because of that midsole stiffness, it actually reduces stress in that area. And we, of course, taught heel lock technique. For the wedding, and this is where Yvonne goes all stylist. So we recommended a nice block heel, something that was deep enough for the toe box and wide, preferably not a round kind of shoe or a round forefoot. And we recommended bringing her orthotics with her for the shopping part of it and to go up a half size max. Don't go too big either, for her wedding shoes, so she could put in a slimline orthotic if possible.
So back to kind of what we see in clinic around physical activity. Physical activity is any movement that requires an energy expenditure from your muscles. And physical activity we know is beneficial for cardiovascular disease, dementia, preventing cancer, improving bone and brain health. So all these types of benefits we have from physical activity. And when we start to talk to patients about physical activity, which includes housework and gardening, not just walking and running and cycling, a lot of patients express fear or concerns around their arthritis flaring if they start doing physical activity, or they may have had a flare because they started trying to walk 10,000 steps and previously they were only doing 2,000 steps. So a lot of fear around pain and fear around making their arthritis worse, or sometimes there's preconceived ideas, because I have psoriatic arthritis, I can't walk or I can't run. We know from the research and from our own clinical experience that exercise can be more effective than paracetamol for pain relief in osteoarthritis, that our joints and our cartilage need loading, so they need exercise to keep them healthy, and that also exercise reduces inflammation in patients with inflammatory arthritis. So with all these benefits of reducing pain, reducing inflammation and fatigue, improving quality of life, improving function, your self-esteem and your mental well-being, how do you go about increasing your physical activity? Thanks, Yvonne. So if we look at, first off, sitting less and moving more. So the less we sit, the less stiffer we're going to be when we get up off the chair. So just that's the first thing to try and start. The international guidelines are to do 150 minutes of physical activity in the week and 2 strength training sessions. So 150 minutes is 5 sessions of 30 minutes a week, or it could be 3 sessions of 10 minutes within the day, 5 days a week. So if you have a little think to yourself now, this is something I ask patients in clinic all of the time, how much can you walk before you need to sit down or before your discomfort or your pain becomes intolerable for you? So say, for instance, you say to me today, Sandra, I can walk 5 minutes, but then I need to sit down. Well, then what I would suggest is that, would you try walking 4 minutes every day this week and see how you get on? And if that goes well, maybe next week do 5 minutes every day. So you're looking at a very graded, small approach. So the body doesn't have to make any big changes. They're not big loads going through the joints. The muscles don't have to work too hard. It's very adaptable. And then we don't get this boom or bust cycle where we try and get up to 10,000 steps and then we get very sore. We don't walk for a few days, or we don't walk for a few weeks again, and we never really hit our targets. Another thing to look at doing is you could look at attending hydrotherapy classes, swimming, aqua aerobics, cycling, chair yoga or normal yoga, Pilates, gardening. So you could look at different ways for yourself to improve and increase your physical activity. And if you're still thinking, this is not accessible for me, or I don't think I can do this, it is worth visiting your local physiotherapist, because they can go through specific exercises to help you build the capacity to increase your physical activity, and they can work on goal setting with you to bring you along to whatever your goal is. So something we can do now, maybe today even, to start off, that you can take away from this webinar is, if we all give this a go, calf raises. So calves are the back of the muscles, or the back of the leg muscles, and they help to stabilize our knee and our ankles. So if you come out to the edge of your chair, if you're sitting down, or you can stand and hold on to a supported surface, and you press the ball of your foot down to the ground as if you're in the beach pressing down to sand, so much so that you're squeezing the muscles of the back of the leg, the calves, the heels start to lift up. Give the muscles a good squeeze and then allow the heels to drop down slowly and control back to the ground. So lift the heels up and press the ball of the foot into the ground and lower them back down. As I'm chatting, you can keep doing that. So we can start this in seated, or if you find you can do 20 of them easily while I'm chatting, you could definitely start in standing. Always do them if you've any forefoot pain in a pair of runners or on a very thick bat mat that you're not going to slip on. And your aim is really to be able to get to 20 single leg calf raises over a period of 12 weeks. But see how you go and see, can you incorporate that into your day, maybe twice a day? And just to note, Karen Quinn is a clinical specialist in Cork who's done lovely videos on the Arthritis Ireland YouTube page, and I've linked in the next slide. So if you need to go back over that again, she has lovely videos there that you can look at. In our arthritic patients, we would notice that a lot of patients have reduced range of motion at the ankle joint, and that's often because tissues of the calf are quite shortened, okay? And this changes how the foot hits the ground and moves us forward and puts other loads through extra parts of the joint. So we'd often see, myself and Yvonne, that the midfoot takes a lot more load because the calf is tight, or the knee or the hip. So calf stretching is something that you can do at home while you're brushing your teeth or making a cup of tea. So if you're standing at a counter with your hands on the counter, bring one leg behind you, place the heel on the ground and the foot is facing forward, not out to the side. Keep the knee straight because the muscles come from the back of the knee down to the back of the heel, and lean forward, and you should feel a very gentle stretch at the back of the calf. If you're feeling discomfort at the front of the ankle, back of the heel, back off it a little bit. Spend 30 seconds there, deep breathing or 5 deep breaths. Repeat it on both sides 3 times. Do this for 8 weeks and you're going to increase your ankle range of motion or your calf length. And the final exercise I will talk to you about today is just balance exercises. Okay, so for some people, standing at a surface without their hands on is a challenge. For someone else, standing on one leg without any hand support is a challenge. So you need to find where your challenge is. So how to do this is to go to a nice steady surface, put both your hands on the surface, take your hands away. Can you stand there without support for 30 seconds? If you can't do that, that's your first goal. If you can do that, put your hands back on the surface, stand on one leg. Can you do that for 30 seconds? If you can do that, then take your hands off. How long can you stand unsupported on one leg? And your aim is then 30 seconds. And these can be progressed or individualized to you by visiting your chartered physiotherapist. We can also look at doing hip strengthening exercises and a lot of foot strengthening exercises if you do have a lot of problems in this area. So again, going for an individualized assessment would be more helpful than generic exercises if you need it. So as I said, this is the link to Karen's lovely YouTube video, and thanks Karen for doing that. And then I want to just direct you to Helen French. Professor Helen French is a physiotherapy lecturer in RCSI in Dublin, and she's also an internationally renowned researcher in the area of arthritis. She's very famous in the physio world. She did a fantastic webinar there in National Arthritis Week for Arthritis Ireland. It's an hour long. It's on their YouTube page and on their website, and it's a brilliant resource if you're interested in physical activity and learning more about it. So for Maura, so if you came to physiotherapy assessment today, we'd go through your history and what your concerns are. And that's what we did with Maura. We went through her list of medications, all her main worries. And as I said previously, her footwear was her main concern. Then I did a full hands-on assessment of her low back, her hips, her knees, her ankles, and her feet. That involves putting my hands on, feeling the joints, checking the ligaments of the joints, checking the muscle length and strength, and also the range of motion of each joint. And I looked at her walking and I videoed that so that I could look back on it again. And then when we put in orthotics and we put in her new shoes, we could video it again and she could see the changes. And also looked at her getting up off the floor because she was finding that difficult. I did a neurological and a vascular assessment, and this is because she did have burning at the bottom of her foot. So it's really important that if you're having burning or pins and needles, someone assesses that for you. And that involves checking the sensation so that you can feel everything and your reflexes as well as your muscle strength. From a treatment point of view then, on the first day I did some hands-on treatment. So I released out her calf muscles, did some joint mobilizations to the midfoot and the forefoot that had gotten tight over time from wearing too tight shoes. And then we gave her exercises to kind of maintain what she'd gained in clinic and build on it. So she was doing her calf stretches 3 times a day while making her cups of tea, and that her range improved, I think 10-15 degrees within the 8 weeks. Strengths, she was able to do 10 double leg calf raises the first day I saw her. Over 12 weeks, she got to her 20 single leg calf raises. And then she was doing hip bridges, which is bum lifts on the bed in the morning, and sit to stand exercises throughout the day, just to build up her lower limb strength. She had a family dog who she'd stopped walking. She said it was a lab. He gained a bit of weight. So she started walking with her dog, and she started with 10 minutes a day and finally got up to 6 weeks. She was doing 30 minutes 5 times a week. And then Yvonne had done her foot health with her. So I asked her when she was applying her creams to do a gentle massage of the calf and the foot to keep that mobility and skin mobility that she'd achieved with physio.
So this is my interview for Off the Rails, if they're still doing that show. So for the wedding, which is obviously so important to Maura, we talked about the shoes earlier. She ended up wearing a court shoe. And we talked about either a long dress or a jumpsuit because it can be a bit flowy at the leg. So if she was conscious about it, it would kind of cover the footwear. And then we recommended for when the party really started that she changed into white runners for dancing. My big style tip, and like I'm not a style guru, but like if you have a fascinator, you can really draw the eye up so that you're looking at the fascinator around the shoes. And as she was mother of the groom, that was so appropriate. A really cool hat is always a good one.
Can I interrupt as well? I had
Yeah.
another gentleman who went to a very posh wedding recently out in Adair Manor, and he was living in this hoka since he'd had his condition. And what we did on was the morning of the wedding, he came in, I taped up his foot so he could wear his dress shoes because his pain had actually started in wearing dress shoes. So then he was able to wear his dress shoes for the ceremony and for the wedding day, and he had no negative outcomes. And actually by doing that, then he started wearing his dress shoes again for formal occasions. But there's always ways to get around these things. So
Yeah.
just think outside the box.
And it's talk to us about it. Like we are human, we get the problems. So like just voice those issues to us. And like we regularly, one of my colleagues recently was doing something for mother of or a father of the bride as well. So like, you know, we can work around these things. So for Maura, we obviously had the slimline orthotic. We gave her the footwear advice, the block or wedge heel if possible, and she changed her footwear. And obviously the exercise prescription, she had improved self-esteem function and she was well able to dance the night away. And she improved her lower limb strength and mobility, and like they all live happily ever after. And there's another long dress that looks fab that nobody's seen your shoes in that outfit.
So just the main takeaway message from today is that it is never too late to start investing in your foot health with foot checks, foot hygiene, and appropriate comfortable footwear. If you do have concerns about your feet, please visit your podiatrist, your physio, your GP, rheumatologist, dermatologist. So specifically, pain that is not resolving or night pain that is waking you and you're unable to get back to sleep. Loss of power in the legs, any falls or new falls. New skin issues, particularly if you're on a biological or a methotrexate, so a disease-modifying agent, because there may be ulceration underneath that corner callus. Hot, red, swollen joints. So there is a bit of research, particularly in rheumatoid, that even if we're on a disease-modifying agent, that a flare can start again at the foot. So if your foot becomes painful, it may be indicative that you need to go back to your rheumatologist and have a look at your medication. Persistent swelling of the lower limbs. So this is something that is of concern and you do need to see your GP. There's something vascular or something else going on there. And perhaps you need to have a look at kidneys, blood pressure, water retention. If you have temperature or color changes to your lower limbs, so they become very hot or very cold, they're black, they're blue, there might be blood supply issues going on there. So again, good to seek out professional help. If you have that single vertical stripe of discoloration on the nail, it can be indicative of melanoma. So again, get that checked out. And pins and needles or burning in the feet can come from other issues. It can come from your spine, from a nerve injury, or can come from vascular issues or blood supply issues. So worth getting that checked out. Thanks, Yvonne.
So obviously where to get help from a podiatry point of view. There's kind of a mixed amount of podiatry within the HSE. So obviously check locally with your rheumatology team. They'll probably know where to direct you. If not, there's a lot of really good private podiatrists. Always double check that they're CORI registered, and that's for any skin or nail issues, for treatment and advice in that area. For any musculoskeletal foot and ankle pain, they can also do a really thorough lower limb vascular and neurological assessment, and for obviously the ulcer management as part of the team in the HSE. So if you are looking for a podiatrist, if you go on to www.podiatryireland.ie, and there's a link to a page called Find a Podiatrist, and you can search your area where you're living.
And from a physio point of view, most rheumatology teams, if you're linked in with your rheumatologist, will now have a physiotherapist, so they can refer you in-house to that physiotherapist. Otherwise, they can refer you to your primary care team physio. And if you're looking for a private physiotherapist, you can either ring that number from Dublin or look up their website, iscp.ie, and they will direct you towards a local chartered physiotherapist in your area. And so just to summarize from today, start doing your foot checks this evening, tomorrow morning, get into the habit, start looking at your footwear, you know, get rid of the shoes that aren't comfortable or just wear them less and get more comfortable shoes so you're supporting your foot health, and do seek help from a professional if you need it. Thank you. So Tara, any questions?
Hi there. Wow, that was very comprehensive. Thank you very much. I have to say I learned so much during that presentation, and thanks, because I can see you put a huge amount of effort into preparing for it. So thanks, Sandra and Yvonne, that was really, really good. We do have some questions, and we don't have a huge amount of time, but the one that comes up time and time again for us is this particular one. It's about somebody who has very swollen ankles and feet, and they find it very hard to get shoes, trainers, or boots to fit. They might be on their feet all day at work and they're so swollen they can hardly walk, but they can't get anything physically onto their feet. Would you have any suggestions for them?
I think we could both answer that question. I'll start from a medical perspective. I would have concerns that there might be something else causing the swelling other than arthritis, that may be fluid retention. So a few tips, definitely go see your GP. But what you could do is you can measure your ankle with a tape measure in the morning and the evening and see if there's a change, and just get a baseline of how swollen the foot actually is. Then see your GP, because you may need a vascular assessment or you may need to look at water retention. So there's a few different professionals involved depending on what the cause is. From a footwear perspective, you know, the other thing is, over time our feet change in size, so maybe you're just wearing the wrong size shoe. And I don't mean to be funny, but I've gone up a size and a half since my last baby. So you might be wearing the wrong size shoe, and also then looking for a wider shoe. Yvonne, from a podiatry point of view?
Yeah, sometimes kind of a lower opening. So if you can pull down the tongue as far as possible, then you're obviously going to get more width and it's easier to get in. If it's a woman, we'd often recommend looking for a men's shoe, and obviously some of the men's shoes can be really stylish now too, especially the runners. Obviously your wider fit, like your pro play runners, especially for work if you are on your feet in work, and the Brooks extra wide fit will be kind of where we'd go there. And obviously if you go to a podiatrist, they probably do a bit of the vascular looking at as well, and we'll probably be able to order you in some footwear that will be extra wide and extra deep as well.
Great, thank you. So there's a question here about Skechers. So somebody said, I've heard Skechers do not provide good support, but other people swear by them. What is the definitive review?
I'll take that one. So Skechers, like every brand, have a variety of styles within them. And obviously their slip-ons are very popular from a point of view, it's easy to slip on, but as we discussed in our footwear bit, like a slip-on shoe is not going to provide you any support and is probably really flexible in the upper. So we would really recommend trying to avoid the slip-on Skechers. And I suppose it's the flexibility of the midsole, and a lot of the Skechers can be quite detrimental if you have a lot of foot pain or a lot of foot pain related to arthritis. So we'd try and avoid if possible. Now, some of them can be really good. Some of their Go Walk section is a lot better, and the depth of them can be really handy to put in an orthotic. We've done that in the past. But it's very much individual. If you have no problems whatsoever and you have a really strong foot, and like you can give Sandra a one-on-one on her exercises, then like it's more important than like they could probably get away with a Sketcher. But for any person with arthritis, that'd be kind of in the line of avoid if possible.
Yeah, okay. Very good. Another question here is from a lady who said that she has osteoarthritis where the laces are tied on both feet and it's causing her pain when she's walking and she's waiting for orthotics. Can you recommend any exercises, or I don't know, maybe would a Velcro shoe be better in that instance, possibly?
What
Yeah.
can help is a heel lock. So if you can get a runner with a heel lock and you use the heel lock, you don't need to tie this. I presume, I could be wrong, Mary, now, but this is maybe what you mean, is it that you're getting pain across here when you're tying the laces. So if you use your heel lock and you capture the heel back into the shoe, you can loosen this out a bit. You also might actually need to go up a half size and shoot. Like, honestly, isn't it true, Yvonne, the amount of patients that are wearing the wrong size shoe when they come into us?
Yeah.
And any exercises, not that, because it's so specific to the mechanics of wearing the laces, I don't think it's exercises, I think it's the fit of your shoe might be the issue. And again, if you're weighting new orthotics, the orthotics could be making the space in the shoe smaller, so you might need a deeper shoe as well.
Yeah, for sure.
Yeah.
And as well, I suppose, look at the padding on the tongue. Some tongues on high street
Yeah.
footwear can be really thin versus a runner is really padded, so you shouldn't feel the laces being tied. You might be tying them too tight either.
Yeah. Okay. There's another question here, actually, and I think it's a really good question. How often do you need to recheck or get new custom orthotics? Because they do wear down. So I think that's a really good question.
That's a great
So,
question.
it's really person specific, like shoe wear. So some people go through shoes really fast, and then they'll probably do that with an orthotic too. Generally speaking, we would say about every 2 to 5 years, and that's just general. Sometimes people come in with like orthotics that are 5, 6 years old and they're in perfect condition. And like it depends on your body weight going through the orthotic as well. So like if we see there that the shell here is quite hard and firm, so that really shouldn't break unless like it's been rolled over by a car or unless a dog has gotten at it and bitten through it. But generally the top cover is what wears a lot of the time, and they can be refurbished. So there's no hard and fast rules because everyone wears an orthotic differently. But like if you're noticing the top cover going and it's uncomfortable, then you need to ring your supplier and ask can it be refurbished, I suppose, is the first line. But like that, as I said, we've seen people come in with orthotics that are years old and they're still functioning fabulously. So
Okay, great. And then there's one other question here, and I think it's probably worth having it investigated. There's somebody looking for pain and numbness in their big toe and forefoot due to nerve damage from spinal arthritis. So any advice for them?
Yeah, Janet, again, you're looking at having your appropriate fitting footwear. So everything we went through with regards to footwear, it depends. So sometimes, if perhaps it's nerve compression from the spine, that may not go, or sometimes it goes years after. So it depends how long you've had it, how acute it is, really. Sometimes if it's just a new numbness, that can go within 6 to 8 weeks, but sometimes it can take years and sometimes it doesn't go. So I would say if you haven't seen a physio, go to a physio and actually have the neurological assessment, and then they can guide you through. But that's like looking into a crystal ball. There's no fast or hard rules with this. Nerves heal at a very slow rate unless there's an instant compression and an instant compression removed. So it's more, I think, to actually get an individualized assessment would be appropriate for you. I hope that answers your question.
Thanks, ladies. That's fantastic. And then there was just another question there from somebody about the list of shoes. And just to let everybody know, the recording will be sent to everybody who registered. So you'll be able to go back through the recording to see the list of shoes that Yvonne and Sandra recommended during the presentation. So don't worry, we will definitely make sure you all get a recording for it. But if you have any questions, you can always email us at communications@arthritisireland.ie as well. I think we're going to have to wrap up there, folks, because we've got a little bit over time. I just want to say thanks so much again to our fantastic speakers, Yvonne and Sandra. I think you've just delivered the most fantastic webinar with so much information. I'm really glad it's recorded because I definitely want to watch it back now as well. Thanks so much for giving us your time, and thanks to everybody who attended. We really appreciate it. And we look forward to seeing you all again soon.